Hello, my name is Leandro Carvalho. I'm an intensive care physician and anesthesiologist in Brazil. Thank Sylvia and the organizing committee for the invitation. This is my second time at the World's Pediatric Conference, and I hope to see you again next year live. The chosen topic for this conference is the international guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. I have no disclosures that concern to the topic of this speech. The Surviving Sepsis campaign published its first international guidelines for the treatment of sepsis in children in early 2020. This is a cooperation between the European Society of Critical Care Medicine and its counterparts in America, the Society of Critical Care Medicine and the World Federation of Pediatric Critical Care Societies. The guidelines have been published in Pediatric Critical Care Medicine in the US and Intensive Care Medicine in Europe. The rationale for guidelines were who, where, and what. Who, a guidance for clinicians caring for children with septic shock and sepsis-associated organ dysfunctions. Where, at the hospital, emergency, or acute care. And what, to be a guided, informed practice. These guidelines were published now because of the importance of sepsis as leading cause of hospital and ICU admission, its high morbidity and mortality. The grade classification tools were used to inform quality of evidence and recommendations. Quality of evidence were labeled as high, moderate, low, and very low. The type of recommendation was labeled as strong against the intervention, conditional against the intervention, conditional for either intervention or the comparison, or conditional for the intervention or strong for the intervention. A strong recommendation would mean for the patients that most individuals in the given situation would want the recommended course of action. A weak recommendation would mean for the patients that the majority of individuals in a given situation would want the suggested course of action, but many would not. A strong recommendation would mean for clinicians that most individuals in a given situation should receive the recommended course of action. A weak recommendation would mean for clinicians that different choices are likely to be appropriate for different patients. A strong recommendation can be adapted as policy in most situations. A weak recommendation would mean that policies will likely be variable. Best practice statements are not formally graded, but can inform the clinicians about a possible course of action. Screening of sepsis is suggested for timely recognition of septic shock and organ dysfunctions. Protocols are recommended for the management of septic shock and organ dysfunctions. Electronic sepsis alert tools can be implemented to automatically detect sepsis. One of the steps of sepsis protocol, the completion of the 1 hour bundle within 1 hour was markedly associated with the reduction of hospital deaths. An emergency department screening, use of antibiotics and fluids in a timely manner has reduced fivefold the death among children with septic shock. The panel could not issue a recommendation about using blood lactate to stratify low versus high risk of septic shock or sepsis. Blood cultures should be obtained before initiating antimicrobial therapy if this does not delay antibiotics. Antibiotics should be started as soon as possible within 1 hour of recognition of septic shock. In children with sepsis but without shock, initiate antibiotics after proper evaluation within 3 hours of recognition. Studies favor initiating antibiotics within 1 hour for shock, and starting antibiotics within 3 hours for suspected sepsis. Empiric, broad-spectrum therapy with 1 or more antimicrobials to cover all likely pathogens are recommended. The panel suggested against routine use of empiric multi-drug therapy without immunocompromise or high risk for multi-drug-resistant pathogens. Otherwise, it suggested the use of empiric multi-drug therapy with immune compromise or high risk for multi-drug-resistant pathogens. Decreased mortality and less treatment failure was seen when used monotherapy than combination therapy. For children with septic shock or other sepsis-associated organ dysfunction who have immune compromise or high risk for multi-drug resistant pathogens, empiric multi-drug therapy is suggested. Once the pathogen and sensitivities are available, antimicrobial therapy should be narrowed. The escalation of antimicrobial therapy must be assessed daily. The duration of antimicrobial therapy is determined according to the site of infection, microbial etiology, response to treatment, and ability to achieve source control. If no pathogen is identified, narrow or stop antimicrobial therapy according to clinical presentation, site of infection, host risk factors, and adequacy of clinical improvement. Emergency source control must be obtained as soon as possible. Remove intravascular devices confirmed to be the source of sepsis or septic shock. Fluid resuscitation should be decided in regard to ICU availability. Monitor markers of cardiac output and fluid overload must be used regularly. If ICU is available, administrate up to 40 to 60 milliliters per kilogram over the first hour. If ICU is not available and there is no hypotension, do not use bolus fluid. If ICU is not available and hypotension is present, administrate up to 40 milliliters per kilogram over the first hour. The additional need for fluids should be guided by reassessment of clinical markers, blood lactate, and hemodynamic monitoring. Crystalloids are preferred for the initial resuscitation of children. Balanced or buffered crystalloids are suggested rather than 0.9% saline. Starch and gelatins are not recommended in the acute resuscitation of children with sepsis or septic shock. Hemodynamic advanced monitoring and lactate trends are used to guide resuscitation. Bedside clinical signs should not be used in isolation to categorize septic shock. You must use advanced hemodynamic variables when available. Trends in blood lactate levels are suggested in addition to clinical assessment to guide resuscitation of children. Epinephrine or norepinephrine are used as preferred vasoactive drugs. Use advanced hemodynamic monitoring and cardiac ultrasound and evaluate individual patient physiology. Epinephrine and norepinephrine are suggested rather than dopamine. Both norepinephrine or epinephrine can be selected as first-line vasoactive infusion. A diluted concentration of the initial vasoactive medication can be administered through a peripheral vein if central venous catheterization is not yet available. Vasopressin can be added in children who require high-dose catecholamines. No recommendation about whether to intubate children with fluid refractory catecholamine-resistant septic shock. You must not use etomidate when intubating children with septic shock or other sepsis-associated organ dysfunction. This is based on two observational studies that associated etomidate with high mortality. Non-invasive mechanical ventilation can be used in children with sepsis-induced respiratory dysfunction who are responded to initial resuscitation. Non-invasive ventilation could be associated with a decreased risk of death. Level of high PEEP has not been determined. You must be aware of adverse effects of high PEEP in shock. Try prone positioning for at least 12 hours a day, and neuromuscular blockade can be used for 24 to 48 hours. Routine use of inhaled nitric oxide in all children with sepsis-induced respiratory dysfunction is not recommended. Nitric oxide as a rescue therapy in children with refractory hypoxemia after other oxygenation strategies have been optimized is suggested. There is no difference in mortality with the use of inhaled nitric oxide, but studies favor ventilator-free days and oxygenation index with this therapy. Recruitment maneuver and high frequency oscillatory ventilation were not suggested nor recommended. Enteral nutrition is preferred over parenteral nutrition in the first 7 days of ICU admission. Late parenteral nutrition decreases infections and increases discharge and survival rates. Enteral feeding is not contraindicated after hemodynamic resuscitation, even if the patient still needs vasoactive agents. Administering enteral feeds through a gastric tube is suggested. Do not measure gastric residual volumes or use prosynergic agents routinely. Nutritional supplements and adjuncts were not suggested. Hydrocortisone should not be used if fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. Hydrocortisone could be used if adequate fluid resuscitation and vasopressor therapy are not able to restore hemodynamic stability. Insulin therapy should not be used to maintain blood glucose target at or below 140 milligrams per deciliter. In practice, target blood glucose level below 180 milligrams per deciliter. Normal blood calcium levels should be targeted for children with septic shock with vasoactive infusion. Routine use of levothyroxine is not suggested. Antipyretic therapy or a permissive approach to fever may both be suggested. Do not transfuse red blood cells if blood hemoglobin is greater than or equal to 7 grams per deciliter in hemodynamically stabilized children with septic shock or other sepsis-associated organ dysfunction. Prophylactic platelet transfusion is not suggested based on platelet levels in non-bleeding children, and prophylactic plasma transfusion is not suggested in non-bleeding children. Plasma exchange should not be used in children without thrombocytopenia-associated multi-organ failure. Renal replacement therapy should be used in children with septic shock or other sepsis-associated organ dysfunction who are unresponsive to fluid restriction and diuretic therapy. High volume hemofiltration should not be used. Extracorporeal veno-venous life support could be used in children with sepsis-induced pediatric acute respiratory distress syndrome and respiratory hypoxia. Immunoglobulins should not be used routinely. Spread use prophylaxis should be used only in high-risk patients. Deep vein thrombosis prophylaxis is not routinely used in critical ill children. And we must discuss how to adapt guidelines to resources available. In different settings, the patient profile will be different. The pathogens will be different. The health systems will be different. All of these factors need to be taken into account. Variations within and across healthcare systems in geographical regions will determine the practical application of these guidelines in low-income countries. These guidelines should constitute a general scheme of best practices, but the translation to treatment algorithms or bundles and standards of care will need to account for variation in the availability of local healthcare resources. Sepsis incidence rate is related to social demographic index, and sepsis mortality rate is more so related to social demographic index. We need to test the adaptation of interventions to locally available resources. And in future, we need to have broad international and multi-professional representation from critical and intensive care medicine, emergency medicine, anesthesiology, neonatology, and infectious disease, with inclusion of physicians, nurses, and pharmacists as part of the working group, and this must be ensured. Panelists should be recruited from a wide number of countries and healthcare systems, including representation from resource-limited geographic areas. And at last, we need to work with the existing guidelines to extract themes and priorities, and align guidelines with the priorities of each community or country, the central development of resources and methodology, and work to make the process accessible to those in need. For more information, visit the Surviving Sepsis Campaign guidelines and the YouTube discussion about these international guidelines. Thank you. See you next year.